So with that, we will go on to the next talk, which is IOL formulae, which and when, by Dr. Sanjali WADHOKAR, but she is actually giving this talk instead of Dr. Gaurav Luthra, who is unable to come for the AIOC. Dr. Sanjali was our fellow, and now she is in practice at Pune, and she will speak on the IOL formula.
Thank you, sir. Thank you, Dr. I would like to thank Dr. Shri Ganesh, sir, and AIOC for this wonderful opportunity. I would like to acknowledge Dr. Gaurav Luthra, sir, and Dr. Sheetal Brar, ma'am, for a few of the slides and the material for this presentation. So I'll be talking about IOL calculation formulas, which and when to use. So the quest for accurate intraocular IOL calculation has been there since the first IOL was implanted by Dr. Harold Ridley, sir, in 1949. Now today, as sir said, cataract surgery is just not cataract surgery. It has become a refractive surgery, where the patient expect the post-operative outcome to be between plus and minus 0.5. Coming to calculation formulas generation wise. So the first generation formula were by Dr. Fydorov, and they were based on the theoretical model of the eye. It was based on a schematic model of the eye, and they were not very accurate to predict the post-op outcome. The second generation formula were based on regression analysis, where the analysis was done based on the post-operative outcomes which were deduced. The third and the fourth generation formula were widely used even till now, and they give fairly accurate results. They are based on Virgin's formula, which is based on the Gaussian optics of the eye, and it is a combination. It's not a very precise classification if we divide it according to the generation, because some of the formulas, they are Virgin based, and some are a combination of the Virgins and theoretical formula. These newer generation formulas, some of them are based on such as Barrett's Universal 2, Hill RBF, and Super TADAS. They are based on ray tracing models and artificial intelligence, which gives us a fairly accurate post-operative outcome these days. This is an overview of the summary of all the LPAR calculation formulas. Here we can see that the earlier generation formulas were fairly precise in the normal axial length, whereas during the extremes of the eye, they did not give a very accurate results. When we come down to Barrett's Universal 2 and Hill RBF, they are fairly accurate to the extremes of the eyes as well. The version formulas were classified into two variable, 3 variable, 4 variable, 5 variable, and 7 variable formulas. The variables included were axial length, keratometry, anterior chamber depth, lens thickness, horizontal white to white, age, and refraction. So briefly talking about the IOL calculation formulas, the SRK-T was a holy grail till now, till the newer generation formula came into picture. It was a theoretical approach to alpha calculation formulas, and it used optimized post-operative anterior chamber depth. It also included retinal thickness correction factors, corneal refractive index, a combination of Hoffa-Q, Holiday 1, SRK-T, and SRK-T worked really well for 22 to 24.5 length of the eye. SRK-T is still used in many of the centers when the IL power is not able to, we are not able to calculate the IL power using the IL master. And it gives fairly accurate results. A combination of, it is recommended for eyes for more than 26 mm. And the Hoffa-Q, it was a very popular formula for pediatric surgeons. It used personalized ACD, which depends on the IOL style. The axial length and corneal curvature, it is used to predict the ELP. ELP is the position where is the state where the IOL it sits in the eye, and it's the most important thing to calculate during when we look at the IOL calculation formulas. It is recommended, Hoffa-Q, it is recommended for eyes less than 22 mm. Holiday 2, it uses 7 factors. It was also very popular till Barrett's Universal 2 came into picture. And Holiday 2, it is recommended for long and short eyes with Van Cox adjustment. So the most popular formula, that is Barrett's Universal 2, it's a Virgin based. The model of the eye in which anterior chamber depth is related to the axial length and keratometry. The A constant and lens factor, they are also used to determine the anterior chamber depth. It is applicable for all types of eye, short, normal, long, and for all types of IOL. And it is also available online, so it is easily accessible for most of the surgeons on APACRS and ASCRS websites. It can also be used for post-refractive surgery and toric calculation. The parameters that are required for calculation of Barrett's Universal 2 are axial length, keratometry, and lens factor. These are the must-have data. The optional parameters are anterior chamber depth, wide to wide, lens thickness, and design factor. Barrett's 2, it is incorporated in ILMaster 700, which includes three formulas, that is Barrett's Universal 2, Barrett's Toric, and Barrett's True K, which is used for post-LVC calculation. Barrett's suit, it is based on a nomogram, and calculates the posterior corneal curvature based on that specific nomogram. The lens factor, it is in the Barrett suit, it is calculated using SRKT constant. The design factor is IOL specific, and it influences the IOL calculation. Without design factor also, you can calculate the IOL power, but it is potentially less precise. Talking briefly about Olsen C and other formulas, Olsen C, it is based on a concept called a C constant. It is a fraction of the lens thickness by which the center of the IOL will locate itself post-operatively. Hill RBF, it is also as accurate as Barrett's Universal 2, and it is based on a precise set of data. If it is not able to calculate the values that you have put, it will give you a value such as out of bounds. It means that they don't have the data for which you are trying to calculate the IOL. Superlada's formula, Kane formula, Evo formula, they are the recent formulas which also work really well. So coming to specific like short eyes, long eyes, post refractive surgery eyes. For short eyes with less than 21 mm, Hoffer Q was fairly accurate, but now most of the people prefer Barrett's Universal 2 as it gives more accurate results. There was a study done by Hill RBF in 2016, which was a prospective study for axial length less than 22.5 mm. It said that Hill RBF, Hoffer Q, Barrett's Universal 2, and Olsen, they all of them gave accurate result for axial length less than 22.5 mm. For longer eyes with axial length more than 25 mm, such as patients with posterior staphylomas, status post-scleral buckle, congenital glaucoma, and ROP. This is a nomogram which told that more than 26 mm SRKT, Olsen P were more accurate. With Bangkok adjustment, most of the formulas work fairly well, but in the end, Barrett's Universal 2 is one formula which suits all of the eyes. For post-corneal transplantation, we can do a primary implantation at the time of the surgery, or we can do a secondary implantation after 6 months after the cornea is healed. The primary implantation is done by using the keratometry of the other eye, or using a standard keratometric value of 3.5 diopter. The secondary IOL implantation is more preferred as it gives lesser refractive surprises. Keratometry by topography can be done using aphakic mode. A refractive version formula, they work well for post-cornea transplantation. For keratoconus, as we know, it gives hyperopic refractive surprises post-operatively. Here, Hage's Hoffer-Q SRK2 formula work well. So to summarize, SRKT formula is recommended for long eyes, whereas Hoffer-Q is recommended for short eyes. The fourth generation formulas, such as Hill RBF3, Barrett's, Hage's, Holiday 2 formula should provide highest accuracy in full range of axial length. We would prefer Barrett's Universal 2 and Hill RBF3 for most of them.